Today's class is going to be actually quite interesting. So I'm going to start it with finishing up what we had left from the beta-lactam antibiotics. So that will be the cephalosporins and also the carbapenem and the azithrionam, and yeah. After that, I will go to Biochem, explain to you the process of translation and the transcription. We spoke about replication already. Replication was taking DNA, making more DNA out of it. And today, hopefully, we'll speak a little bit about the transcription, which is taking DNA and making RNA out of it. And then translation, which is taking the RNA and making a protein out of it. So let's start first of all with our discussion about cephalosporin. I hope you did the sketch for today. The mechanism of cephalosporin is the exact same as to any other beta-lactam antibiotic like penicillin. So the drug inhibits the cell wall synthesis. Can someone remind me, please, where does the beta-lactam ring bind to? Where does the beta-lactam ring bind to? Absolutely, the penicillin binding protein. The penicillin binding protein. And after that binding, which thing will be disturbed? Is it the cell membrane? Is it the cell wall? Or is it the peptidoglycan layer? What will get disturbed? The peptidoglycan layer, absolutely, yes. So beta-lactam drugs that inhibit cell wall synthesis but are less susceptible to penicillinase. Yes, it's bactericidal again, which means it killed the bacteria. Bacteriostatics, like just put it in a state of a freeze. Bactericidal kills it. Organisms typically not covered by first to fourth generation are lame, which means none of these, well, first, second, third, fourth generation work at. So we actually do have a fifth generation. We have a fifth generation. Yeah, the fifth generation can cover the atypical ones, which are the lame one. So that will be Listeria. Can somebody tell me which antibiotic, beta-lactam antibiotic, we love to use for Listeria? Ampicillin. And we use it in case of meningitis in addition to which other two antibiotics for meningitis? Come on. Vancomycin and ceftriaxone, absolutely correct. Good. So the lame ones are Listeria, the atypicals like chlamydia and mycoplasma, MRSA, and enterococcus. Okay, so let's take a look. For MRSA, which antibiotic did we use for MRSA? Vanco as well, absolutely. For enterococci, for the susceptible ones, you can use vancomycin, but most of them are resistant, so we have to use tigracycline and linezolid. Okay, absolutely. So the clinical use, we have all of 5 generations. Guys, I have to say, without Biochem+micro for this one especially, it's kind of really difficult to keep them straight because like there's so many of them. And there is so much stuff going on that makes it quite difficult to grab it all in one look. You must have some memory hook for it, you know? So this is your memory hook. This is what you need to deal with. So let's speak about these generation one at a time. So this guy is the first generation, second, third, fourth, and fifth. So if we go here and okay, so momento. Yes, so if we come here and we speak about all of the cephalosporins, the first type is called the first generation. We have 2 types. We have the cefazolin and cephalaxin, which is used for the gram-positive cocci, and also it's used against the Proteus mirabilis, E. coli, and the Klebsiella. Here is the thing. It's the big type of pneumonic. I prefer to memorize this one. Why? Because here it will be big, here it will be hens big, which is the big is the actual same organism, which are basically the Proteus mirabilis, E. coli, and Klebsiella again. And yeah, so that helps. So to be fair with you guys, in real life, cefazolin is the favorite drug for surgeons. We use it prior to the surgeries because it prevents the Staph aureus wound infection. And keep in mind, is a Staph aureus wound infection common or uncommon? Pretty common. What is the most common place for Staph aureus to hide in our body? Okay, so absolutely correct. So if we speak about it, is the most common place is the nose. They hide in the nose, they proliferate in the nose, they colonize the nose, and then they spread. Okay, so and if you take a look here at the picture, you can see, yes, you can see this is the first generation cephalosporin, mostly working at the purple one, which represents what? What does the color purple here represent in the first generation? Like cephalaxine, all of these ones. Yes, it represents the gram-positive stuff. Absolutely. Okay. What does this cup represent, guys? This cup? UTIs, absolutely. It can be used in the treatment of the UTIs as well. Nice. So the second generation cephalosporin, we have the cefaclor, cefoxitin, cefuroxime, and cefotitan. As I said before, memorizing this is just painful. So for the sake of making painless, I gave you the task yesterday of watching this video because it organizes each one on its place. So the second generation cephalosporin work again against the big, but in addition, it works against the hens. So it works obviously against the gram-positive. In addition, it works against the Haemophilus influenza, Enterobacter, and Neisseria. So that's the hens. And the S is for Serratia marcinus. Guys, for Serratia, we said which patient at a high susceptibility for Serratia, which patient tend to have Serratia much more often? Dirty ones. No, that was like I said that because you find it in dirty bathrooms, but no, not these ones. Actually, the people who have which primary immunodeficiency? Which primary immunodeficiency increase your risk of Staphylococcus aureus, Serratia, Staph epidermidis? All of these have one thing in common. All of them are catalase positive. So which disease increase your susceptibility for catalase positive organism? Absolutely, chronic granulomatous disease, which was a defect in what? Does anybody remember it was defect in what? The NADPH oxidase and the respiratory burst. Absolutely correct. So Proteus mirabilis as well, E. coli and Klebsiella, which is the same organism they used to be here. So that's why I like to remember like the big and the hens big. That's it. The third generation cephalosporin, I have to be fair, guys. People right now are really overusing this one. Third generation cephalosporin, it exists in cefitriaxone and cefotaxime, cefobudoxime and cefatazidine, and cefoxime. In UTIs, that's true. Like even today, I was speaking with a surgeon and he said that they use cefitriaxone for the prophylaxis before the surgery. And I was like, why do you do that? Shouldn't you like be using like cefazolin? He was like, yeah, but they are getting resistant. But for the sake of USMLE, keep cefazolin, okay? Do not choose third generation cephalosporin. That's first thing. Second thing, never ask a surgeon which antibiotic to give because they have no idea. So, yep. If we speak about the third generation, we have cifetriaxone, cefotaxime, cefobudoxime, and cefadizidime. A lot of names that difficult to memorize if you did not do sketchy. So serious gram-negative infection can be covered by this one, which are resistant to other beta-lactams. So the third generation, we can say that it has quite a wide spectrum. And if you take a look at its coverage, you notice here in the beginning it was only the Biggs organism, yeah? And you see here behind him there's surgical tools which tell you that it's like for surgery, like pre-surgery type of thing. And if you take a look at this one, his drinking a tea, cefotaxime. And anyway, so if we speak about the hen's pick, so this is the hen's pick. You notice here we have both a gram-positive and some gram-negative organism. Now the ceftriaxone with the 3-axis is really wide spectrum. As you can see, he covers so many things. And what does the chandelier represent? What does the chandelier represent? Gonorrhea, BID, absolutely, pelvic inflammatory disease, which also can be covered with ceftriaxone, Haemophilus influenza. Yep. And here we can see Robbins of Ixodes. What was that? We know Robbins of Ixodes. Yes, from the other video, Lyme disease, absolutely. So yeah, as you can see, he's quite a wide spectrum type of a drug. That's why people are using it much more than they should. So it can cross the blood-brain barrier, which makes it works perfectly for the meningitis. So we use it for meningitis, gonorrhea, and disseminated Lyme disease. The cefotaxime is for Pseudomonas. Guys, to be fair with you, the actual difference between ceftriaxone and cefotaxime, because it's the only one that can be asked for you. So ceftriaxone, is it parenteral or oral? If we speak about ceftriaxone. Ceftriaxone cannot be oral. Ceftriaxone is IV or IM. But cefotaxime is oral. Okay? Cefotaxime is oral. So the fourth generation is working against the gram-negative organism mainly, with increased activity against the Pseudomonas and the gram-positive. So it's even wider type of action. Guys, since it's wider action, should we use it in everybody? I mean, it's wide type of action. If you use it in everybody, you treat everybody. It seems like a good idea. Why not? Resistance, absolutely. That's why you always, if you have some type of bacterial infection, when you order the culture, make sure you order the culture together with the which antibiotic will be the correct one to use. I will teach you how they do that actually. They bring basically in vitro antibiotics resistance. Yes. So basically in vitro, they bring like this media, okay? And on this media, they put, antibiotic 1, antibiotic 2, 3, 4, 5, and whatever. And then they put the bacteria, yes? So, as you can see, the bacteria is able to move fully. That means that it is resistant or sensitive. So, let's take this one. Okay, I will number them. So this is 1, 2, 3, 4, and 5. So which of these 5 types of bacteria is resistant to the antibiotic? Well, let's see the third answer. Well, to be fair with you guys, the idea is like this. This whole thing is full with what? It's full with bacteria. So these little points that they put, they are the what? They are the antibiotics, yeah? So it's killing here. So that's sensitive. But these guys are not sensitive, they are resistant. So this whole culture is full with bacteria, and this little dots represents the antibiotic, yeah? So it will be 2, 4, and 5, absolutely, yes. 2, 4, and 5 are resistant. There is antibiotic on them, but they don't care actually. They are still growing normally like it does not exist. So, okay, so you need to check for that before starting the antibiotic, and start the exact antibiotic and the least modern antibiotic that works, okay? So, serious gram-negative infection can be treated with the 3rd generation, as we said. Oh, done with this one. Okay, cefabime, it's a gram-negative organism and the gram-positive and the pseudomonas. Notice something here. For this 3rd generation cephalosporin, it does not work against the pseudomonas except for TAZ, okay? TAZ for pseudomonas, yeah? Hopefully you did the sketchy. TAZ for pseudomonas. And it works for the fourth generation. The 4th generation cephalosporin, all of them works against pseudomonas. And by all of them, I mean only cefabime, okay? And the 5th generation, it's a really wide spectrum of action, but it does not cover pseudomonas. So far, between all of the cephalosporin, and they do ask about this, the only two cephalosporin that covered pseudomonas were what? What were they? TAZ for pseudomonas and cefabime. That's it. That's it. Okay. So the 5th generation is ceftaroline. It's a broad gram-positive and gram-negative organisms. Basically works against everything. Okay. Unlike 1st until 4th generation of cephalosporin, it does cover MRSA and it does cover Enterococcus faecalis, but it does not cover the pseudomonas. The only things that cover the pseudomonas were the TAZ and the cefabime. That's it. So yeah, nice. Okay, the adverse effect of these drugs are kind of the beta-lactam antibiotic, like the other ones. They can lead to hypersensitivity reaction. They can lead to autoimmune hemolytic anemia. Well, look, in sketchy, when you watch the bacteriology, you watch a Biochem+micro. And if you watch the sketchy pharmacology, which is like the one I told you about, this one, I think they mention it. They should mention it. I hope they do, actually. MRSA. So this is the pseudomonas between the two. And where is the MRSA? Oh, yep. Here is the guy. Okay. So they must do it. Sketchy is nice, like truly. It has, oh, here it is. Can you see the statue? Yep. Always the ferron. Yeah, the mercy ferron. Not that mercy. So, anyway, speaking about the MRSA, it's also covered by other drugs, but if you speak about sketchy microbiology, yes, they speak about vancomycin, because to be fair, would you use vancomycin or 5th generation cephalosporin that was invented like 10 years ago, which is new, it means it's pretty new? You will use vanco. We want to keep the 5th generation cephalosporin for the next 10 years. So when we will have widespread resistance for vancomycin, we'll have something to fight this bacteria against. So I felt like the day before yesterday when I told you about this resistance, I scared you a little bit. But to be fair with you guys, yes, there is resistance, but there is work in a new antibiotics still. So yeah, constant resistance exists, but constant development of a new antibiotic also exists. So, disulfiram-like reaction. Let me explain this one. This is just a pure biochemistry. So, in the biochemistry chapter, I will be explaining the metabolism of alcohol. I mean, drinkable alcohol, the ethanol. So, if we speak about the ethanol, when it gets metabolized, it gets, just a momento. Yes, here it is. If we speak about the ethanol, it gets metabolized to acetylaldehyde. And that acetaldehyde, it gets converted into acetate. So disulfiram and disulfiram-like products inhibit the acetaldehyde dehydrogenase. So we will have a lot of acetaldehyde. If your body have a lot of acetaldehyde, which symptoms are you going to develop? Well, let me make it simple for you. Hangover. So when you have, if you get drunk and then, yes, exactly, this one. No, not this one. So, oh my God, wrong movie. So it's like hangover, okay? So it's like someone got drunk and then stopped drinking. So they wake up the second day, they have all of these symptoms. Problem concentrating, irritability, nausea, dry mouth, they want to vomit, they have a really bad time. Yes? All of these are from what? The accumulation of acetaldehyde. So when we give a disulfiram, which exists in some drugs, such as metronidazole, for example, or even the drug we are speaking about it right now, some cephalosporin, that also can lead to accumulation of acetaldehyde, which lead to the symptoms we just spoke about, which are flushing, headache, nausea, all of this stuff. Okay, so the next one is about, yes, the next one is about like, okay, the disulfiram-like reaction. I hope it makes sense. It acts like the disulfiram inhibits the acetaldehyde dehydrogenase, more acetaldehyde in your body, like the hangover symptoms type of thing. And it's really, really bad. So you tell your patient, while you are on this drug, you should not consume what? What he should not consume? Alcohol, because that will just exacerbate it. It will just make it worse. Okay, so vitamin K deficiency. How can an antibiotic lead to vitamin K deficiency? How can an antibiotic lead to vitamin K deficiency? Well, not really. Well, let me explain it actually. It's really interesting. So where does vitamin K produced inside of the body? Nope, it is stored in the liver, but it's not produced in the liver. So actually it's produced in the intestinal bacteria. I mean, the normal flora inside of your intestine makes you vitamin K. You're like, wait a second, are you telling me that in addition to the vitamin K I get with food, there is an actual vitamin K produced inside of my intestine by the bacteria? The answer is absolutely correct. So guys, if I use an antibiotic that will sterilize my gut, what is going to happen to my vitamin K level? It will go down. So if it will go down, vitamin K is responsible for the hypo or hypercoagulability. Hyper. So if I lose it, I will get hypocoagulability. That means I will have more MIs, or I'm going to have more bleeding. More bleeding, absolutely. No, not MI. I'm saying you lose vitamin K. Vitamin K is hypercoagulable. It helps you to make the clots. So if you lose it, because you cannot produce it anymore, because you have removed the bacteria from the intestine by consuming a cephalosporin or any other antibiotic, that will get you the problem. Now I have a question, guys. A little baby, like he was just born, does he have a sterile gut, or he has this intestinal bacteria? Is it sterile or not? It's sterile. So can he make vitamin K, the baby? He does not. Absolutely correct. So we must give each baby that is born, we must give him an IM vitamin K What else do we give the baby? Come on, guys. Tell me. Quick. No time. What other vitamin? Okay, we give the Hep B vaccine. Absolutely. Hep B vaccine. Vitamin D. And we also give iron. No need for the B12. It can pass through the breast milk. But this stuff cannot. So you must give them. Okay? So, if we speak about the low rate of cross-reactivity, even in penicillin allergic patient. So actually this is important. Someone who's allergic to penicillin, it's possible that he's going to be also allergic to cephalosporin. But most of the time, in reality, he is not. Keep in mind that it increases the nephrotoxicity with aminoglycoside, especially the aminoglycoside are the nephrotoxic, not the cephalosporin, but they just increase their efficacy. I mean the aminoglycoside. So the cephalosporin increased the efficacy of the aminoglycoside to lead more adverse effect. Well, how the bacteria became resistant to the cephalosporin? Well, basically they were like, are you a beta-lactam antibiotic? He was like, yes, I am. I'm a broad beta-lactam antibiotic. They were like, excellent for you. So they made a type of beta-lactamase that can attack him and kill him. Also, they led to structural changes in the penicillin binding protein, which is also called the transpeptidase. So the cephalosporin cannot bind to it anymore, which was the exact same mechanism of resistance for the normal penicillin. Okay, now we will speak about carbapenem and ezetronam. Well, carbapenem and ezetronam are not that old. If we speak about this drug, for example, market, I'm not sure when it was improved, like FDA approved, but what I know for sure that, yeah, it was discovered in 1976, but still probably it was used much more later. But if we speak about this drug, most important thing to know about them, that you don't want to use them. Why I don't want to use them? Is it because of their bad side effects, or because we are afraid that the bacteria will have new types of resistance against them and they are the last resort? The resistance. So guys, carbapenem are actually quite good, and they are the best of the best. And we are super afraid that we are going to get resistant against them. So we don't prescribe them, except if seriously the patient is going to die if you don't prescribe this to them. So carbapenem, we have the binam. So we have doripenem, imipenem, meropenem, and ertapenem. Okay? So the mechanism. The imipenem is a broad spectrum antibiotic. It's a beta-lactamase resistant carbapenem, which means if you make a beta-lactamase against it, he will be like, ha ha ha, not against me, man. That won't work for you. You need something else. Beta-lactamases won't work against me. So if you look at the structure of it, the beta-lactam ring is a little bit altered from the normal one, and it's well hidden, so it cannot be attacked easily. And if we come back here, it just has different structure, but we need to administrate it with something called cilastatin, which is basically something like this. Inside of our kidneys, there is something called dehydropeptidase that normally lead to basically destruction of the carbapenem inside of our kidney. So when we inhibit it, what is going to happen to the bioavailability of the drug inside of the serum? Can someone tell me what is going to happen to the bioavailability of the drug inside of the serum? High, it will go up. So you cannot clear it anymore. So its amount inside of the serum is going up. So if that is true, it's good because you can keep more drug inside of the body for longer periods of time. So that's what they write. It's administered with the cilastatin, which is an inhibitor of renal dehydropeptidase. to decrease the inactivation of the drug inside of the renal tubule. So the dihydropeptidase is located in the renal tubule, and normally it destroys the carbamidinam. So we give 2 at once, so we will not have destruction of this drug inside of the kidney, and we will have more bioavailability of it. Okay, so basically these drugs, when they prescribe them, they always come with each other. Okay, they don't prescribe like one of them alone. They come in the same type of injection or tablet. So you can see here, for example, imipenem and cilastatine. See, 500 milligrams of this guy, 500 milligrams of this guy. So they come with the same bill for you not to do something stupid and taking one bill only. So one of them has the one drug, the other one has the next drug. So with imipenem, the kill is lasting with celastin. So it will keep it lasting with celastin. I hope you did that sketchy video. Keep it lasting with celastin. So newer carbamidinam include artabinam, have a limited coverage of pseudomonas, and doribinam. So ertabinam and doribinam are the newest of the newest. So we would like to use them more, correct? Not a good idea. We will not use them more because that would lead to resistance more. Okay, the clinical usage is for, notice, a gram-positive cocci, a gram-negative rod, and anaerobe. Only the gram-positive rod and the gram-negative cocci are not covered by this drug. It has wide spectrum and significant side effect limit the use to life-threatening infection. So we are super scared that we are going to get resistant. Also, he has some serious CNS toxicity, so you need to be careful. We only use it for the life-threatening infection that for sure are going to kill that patient, or when the other drugs have failed and we use carbamidinam as the last resort. Meropenem has a reduced risk of seizure and is stable to dihydropeptidase 1. So this is important. That means that the meropenem you might be able to use it alone or not. Tell me, can I use meropenem alone without celastin? The answer, yes, I can, because it's stable to that degrading enzyme, which was what normally found inside of the kidney. Yes. So if I don't have this degrading enzyme that normally found inside of the kidney, well, if it's resistant to it, he cannot destroy it, so we'll have more bioavailability of it. The adverse effects include GI distress, rash, and CNS toxicity, which include seizures. Okay, the seizures is a super serious side effect, especially at higher dosage. The mechanism of the resistance, remember, is the carbamidinam sensitive or resistant for the penicillinase? Well, the carbamidinam is resistant to the penicillinase. Notice here, beta-lactamase is resistant carbamidinam. He's resistant to it. He does not care about this beta-lactamases. So the bacteria was like, damn it, this man is new and he knows our trick. So we cannot use a beta-lactamases against him. What should we do? So they held a meeting. And after holding that meeting, they decided to make something more interesting. They made a what? A carbamidinamase. Yes, carbamidinamase that is especially produced against it. And the organisms that were the most likely to do it were these guys, the enterococci, the E. coli, and the Klebsiella. Okay, so yeah, they made it and they start fighting him off, especially the gram-negative ones. The last drug I'm going to tell you before the break is the estrionam, which is it's less susceptible to beta-lactamases again. It prevents the peptidoglycan cross-linking by binding to penicillin binding protein 3. I cannot tell you how important is this letter 3. They keep putting you many options, and they will tell you penicillin binding protein 1, 2, 3. You have to choose 3. If you forget about this one, the name of the drug is as 3-UNAM, okay? It's a 3. So it has a synergistic effect of aminoglycoside. The word synergism means that if aminoglycoside kills 20% of the bacteria and azetrionam kills 20% of the bacteria, the sum of the effect is going to be 40% or more. Tell me, please. So, more, absolutely. That's what synergism means. It's like 20% of the bacteria, but when you use them together, it will kill like 70%. So, guys, does anybody know how does aminoglycoside work? Anyone? Okay, so it just, yes, absolutely. It works at the ribosome, which decreases the translation. The ribosome are inside of the cells, inside of the cytosol. Yes? So there is a cell, there is a nucleus, and let's say we have ribosomes here, 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 and here. Let's say the A represents the aminoglycosides, and the as, okay, represent the azetrionam. If I give aminoglycoside alone, will he be able just to penetrate the cell directly, or it's kind of difficult for him? It's actually kind of difficult. He needs to use special boards, the boreans, and to get in, so it's really difficult. Then, if we use them together, the azetrionam will destroy the peptidoglycan layer. So the walls will be naked now. So the aminoglycoside can go directly and bind to the aminoglycoside. That makes the effect much more stronger. So they say no cross allergenicity with penicillin. So if you are allergic to penicillin, don't worry, you will not be allergic to azetrionam. The clinical use that it's only used for the gram-negative road, no activity against any gram-positive road or anaerobe. So for penicillin allergic patient and those who have renal insufficiency, who cannot tolerate aminoglycoside. Who cannot tolerate aminoglycoside? People with nephrotoxicity and people with ototoxicity, okay? They cannot tolerate aminoglycoside. So, or kidney failure, so you have to give azetrionam instead. The adverse effect, it's usually not toxic, some GIT upset. Wow, nice drug. Should we use it always? The answer is no, because of the resistant. Yes? Okay, good. So that's all of the beta-lactam antibiotic. So now we'll have a little break. After the break, we'll come back. We'll speak about a little bit of biochem. I would like to explain for you the DNA repair after the replication process that occurred, tell you about some mutations, speak with you about the lac aberon as well. Okay, so see you guys in 10 minutes. Start the recording. Okay, it's recording. So let's continue. Now we are going to speak about the... Yes. So we are going to speak about the DNA repair. So sometimes when we do this pairing of the chromosomes, guys, like we spoke about yesterday that we have that, like, if you remember, I told you like we have 2 strands, and let's say we have like the 3' end, and then we have 1 nucleotide, we have another nucleotide, we have another nucleotide, we have the 5' end. Of course, it keeps continuing to this side and to this side. So the strand next to it will be the opposite way, so it will be 5' to 3', yes, to the 3' end. And now I have a question, guys. If the first strand had adenine, what it will face? What the adenine will face? Adenine takes thymine. Guanine takes cytosine. Cytosine takes guanine. Okay, so the bond between the adenine and the thymine, how do we call the bond between these two nucleotides? It has a name. Absolutely correct. It's the hydrogen bond. How many hydrogen bound between adenine and thymine? 2. How many bonds between guanine and cytosine? 3. How many? And this is 3 as well. Okay, what do we name this bound here? I mean between two nucleotides. Phosphodiester bond. Phosphodiester bond. Which one is more strongest? Is it this phosphodiester bond or the hydrogen bond? Which one is more stronger? Well, the most strongest bond is the phosphodiester bond. Yes. So, okay, now we have a DNA repair. Yesterday, we have replicated the DNA. We had one strand and we made 2 strands out of it. Today, we are going to see which mistake can occur during this process and how can we fix them. So we have double-stranded fixing and we will have the single-stranded fixing. So starting with the double-stranded fixing, non-homologous end joining, okay? So what's up with this? Well, basically, we had our friend, where it is, yes, we had the proofreading process happening, and if you remember previous time, we spoke about how the proofreading happens between, like from the 3' to the 5' with the help of DNA polymerase number 3. During the proofreading process, if the DNA polymerase 3 finds something, well, not okay, for example, instead of a guanine connected with a cytosine, he sees guanine with a guanine. Is this okay, or he should remove it? He should remove it, and he does that. He removes it. So we have 2 types of removal and how we deal with them. It does not remove 1 or 2. That's the thing about this, the endonuclease. He should remove only 1, but sometimes he can do something like this. He removes 2 at a time, or sometimes even more. So we have the non-homologous end joining. It brings together the 2 ends of the DNA fragments to repair double-stranded breaks. So let me tell you for a moment what that means. Well, the best way to explain this is to draw it. So we have, first of all, let's imagine that this is our first strand of DNA, okay? And this is our second strand of DNA. Of course, as always, it's like 3', 5', 3' to 5'. Yes? The DNA polymerase will come and he will be doing the proofreading. Yes? He's like, does he go 3' to 5' or 5' to 3'? Yes, he goes like this. In one strand, 3' to 5', and the different DNA polymerase number 3 from the 3' to 5'. He checks every single nucleotide. Let's say he finds a problem here. What he will do with it if he finds a problem here? Yes, he will cut it. Okay, he cuts it. And let's say that he kept going and he moved here and he found one problem here. He should also, what to do? Cut it. Okay, so he cut both of them. His function has ended and he's gone. Good. Now we have 2 cuts, not in the correct place, as you can see. They are in totally different places. They are completely incorrect. So, but look what happens. Serious problem happens right now, which is this. See this guy? Oops. Okay, let's see how can I move that. Oh no, that will not work. Okay, maybe if I do this. Okay, that would not work. But basically, this one will be pulled out and attach here, and this one will be pulled out and attach here. Yes, so this will be pulled here and attach here, and this will be pulled here and attach here, which leads something like this to happen. So it will be shorter, of course, and from this side, yeah, come on. So I hope you get it. Just like from this side, it's going to become like this. Yeah. You notice that this area has been wrong. I mean, it moved to the wrong place. It's connected to the wrong place, and the whole thing now will just get messed up. Yes, it should not be here, but this portion has moved and shifted to this side. It has shifted to this side. So you have two mistakes that have occurred in the chromosome at different places. Okay, so this is non-homologous enjoining. It's not perfect, but it's better than nothing. That's the idea. It's just like, oh, yeah, so we have a different cut here, a weird cut. Just stick it together with the glue. It's fine, you know? So that's how it goes. Well, is this super bad? It's like a stupid repair. Absolutely. Just glue it up, you know? It's not the best. It's not the best, obviously. But if it's not existing, it leads to super serious problem. Even the stupid repair is better than no repair. Yeah? So non-homologous enjoining, it just attaches the areas to each other, just stick it to each other, as you can see. So brings together two ends of the DNA fragments to repair double-stranded breaks. It has a defect in ataxia telangiectasia. So homology is not required. As I said, we don't care how it looks like. We just attach them to each other. Stupid repair, I like that word. Some DNA might be lost. Who cares? Because some of it will be lost and we will just attach it anyhow. So I have a question, guys. If someone has one leg taller than the other leg, will he be able to move normally, or he will have ataxia? I mean, if someone has no homology of his legs, will he have ataxia? Yeah. So that's the mnemonic. If you have no homology of your legs, you will get ataxia telangiectasia. Okay? So ataxia telangiectasia, where did we speak about this disease? The immunology, it was one type of the primary immunodeficiencies. Do you remember which patient, do you remember what I told you these patients should not be exposed for? The X-ray, irradiation, absolutely. Because if they get a defect, can they repair it? They cannot repair it. So what they will get? Cancer, absolutely. We don't want them to get the cancer, so we reduce their exposure to radiation. Now we are still speaking about the double-stranded DNA, but now we are speaking about a procedure that is much more like modern. Okay, so this is the homologous recombination. He's elegant. He do it correctly, and he makes sure that every nucleotide faces the correct nucleotide, and he adds or remove the damaged the portion. So it requires two homologies of the DNA duplexes, like the one cuts. Look, the exact same cut, but the only difference here that there was not stupid movement, but no, it's totally homological to the other strand. A strand from the damaged DNA, double-stranded DNA, is repaired using complementary strand from the intact homologous DNA as a template. Let me explain how that works. Well, let's say that, okay, this one is fine. So let's say that we have, this one has been broken. Let's say it's located at chromosome, I don't know, 12, okay? So how many alleles do we have in one chromosome? 2 of them. Absolutely. So since you have that, so you have, does that mean that I have 2 chromosome 12? Well, we actually do that, we do have that, but yeah, you are right. We have two alleles, okay? So you have two alleles, yes, you have two alleles, two chromatin of the chromosome. Okay, let's say we defected that one. This one is homologous to it, yes? So I use the other one as a template for the first one. So you're like, shit, I lost some part and I have no idea where. Yes, absolutely. You are like, oh, damn it. So I lost some part here. I have no idea what it was. So see, I lost it here. I don't know what it was. I don't know the sequence. So I'm like, what should I do? Well, let's take a look at my twin brother, because he has my exact same sequence. Yeah? So the other allele has the exact same sequence, which is here. And you take that, use it as a template, and fill up the gaps. And you take the other one as a template and fill up the gaps. So you get two newly perfect homologous recombination. I hope that makes sense. Then we are screwed, I guess. Oh yeah. So that's cancer. So homologous recombination requires two homologies of DNA duplexes. A strand from the damaged DNAs, double-stranded DNA, is repaired using complementary strand from an intact DNA, double-stranded DNA, as a template. So as I said, we take this one, which is the totally normal one, and we use it as a template to correct our mistake. Well, wait a second. Are we the one doing that, or it's just our body automatically doing this? All of this super complicated DNA repairs mechanism. Who's doing that? It's automatic. We don't have to relate with that. Actually, when we do relate to that, we have cancers. So homologous recombination, when it fails, we can have some mutations, like breast, ovarian cancers, like for example in the state of BRCA. Yeah, so BRCA mutation is associated with ovarian cancer and breast cancer, and also Fanconi anemia. Yeah, so Fanconi anemia is associated with also a homologous recombination defect. Remember, guys, who's more elegant and more careful about the homology of how their gene look like and how they look like, ladies or men? Obviously ladies. So the breast and ovarian cancer is for the homologous one, and the ataxic guy does not really care. He has two legs, one taller than the other. That's why he's ataxic, because he has non-homologous legs, leading him to ataxia. So when we speak about this type of homologous recombination, we are not losing anything. So that we will restore the duplex accurately without losing any nucleotide, because the template was just perfect. So let's speak about the next one, which is actually quite interesting. This was a defect in double strands. Now we are going to speak about a single strand. I mean, on the single strand, we might have a problem with the nucleotide excision repair, with the base excision repair, or a mismatch. Let's speak about all of these. So if we speak about the first one, which is the nucleotide excision repair, they say specific endonucleases releases oligonucleotide. When I say oligo, it means like a small number of a nucleotide containing damaged bases. So these endonucleases will be, let's say, oh, we have this is the sequence, this is one strand, and this is the second strand. Let's say the first strand was affected by UV exposure, which led to formation of a pyrimidine dimer. Is pyrimidine dimer okay, or should we remove it immediately not to get cancer? We should remove it immediately not to get cancer. So how do we remove it? The endonuclease notice, oh, something is messed up here. Let me cut the whole thing and take it out and bring you a new base. So that's a nucleotide excision repair. So they write, it's a specific nuclease releases oligonucleotide, like a few nucleotide, as you can see, containing the damaged base, as you can see here. And the DNA polymerase and ligase fill up and reseal the gap respectively. So the DNA polymerase after this is empty. We cannot leave it empty. So the DNA polymerase come. It starts filling up and close up the gap. Yeah, but as always we have some area left and ligase take care of that. Okay. So, nucleotide excision repair, it occurs in G1 phase of the cell cycle. It's defective in the xeroderma pigmentosa. Okay? This disease, xeroderma pigmentosa, we heard about it. Well, we did not speak about it fully. We will see it in another system. But what I want you to know, that in this disease, we are unable to do nucleotide excision repair. So if we cannot do nucleotide excision repair, can we protect us? Can we have a protective mechanism against the pyrimidine dimer formed by the UV light? The answer is absolutely no. So what should we do? What should we tell our patient with xeroderma pigmentosa? I mean, we cannot do anything on a genetic level, so we just need to reduce the UV exposure by, yes, absolutely. Yep. Guys, by the way, I want you to be careful about one question. I saw it somewhere and I think it's highly likely to be asked for you. They might tell you about someone with the symptoms of xeroderma pigmentosa and then they tell you, oh, he's 6 months old. Okay? Now that's a throw off. You want to answer like, and they want to take him to the beach, you know, where there is a lot of sun, and he's having xeroderma pigmentosa. You know that might lead to cancer. The answer says, 1, sunscreen. But give him sunscreen. I don't know if you know this. There is sunscreen has type, like it has, 15 and the 30 SPF. Which is the sun protective factor, stuff like that. If they tell you, oh, should you give him the sun protective factor number 15, sun protective factor number 30, it's a different types of basically sunscreens. Or should you give him like clothes, I mean full cover all over his body? Yes, guys, until 1 year of age, do not put the sunscreen. Just cover the whole baby. I mean, put him in something that will hide all of his body. Sunscreen is not a good idea for babies, okay? So, because they might eat it, they might do stupid thing with it, so no, don't give them the sunscreen. So, defective in xeroderma pigmentosa, inability to repair the DNA pyrimidine dimers that was created by the UV light. It presents with a dry skin, photosensitivity, and skin cancer. Okay, that's xeroderma pigmentosa. Do not confuse it with ataxia telangiectasia due to the non-homologous end joining. Okay, so let's speak about the next one. Guys, can somebody remind me, please? What is a nucleotide made out of? What is a nucleotide made out of? We have a base, nitrogenous base, sugar, and a phosphate. Now let's say we only have a problem at a base excision repair. So the problem is only at a what? At one base. That's it. It's not the whole thing. It's just one base defective. So let's take a look at a nucleotide with all of its bounds. Hopefully I will find something with numbers. Come on. Oh yeah, perfecto. You will see why I was looking for the one with numbers in a second. So here you go. Look what they write. During base excision repair, to get the base only, it's not an easy process. You need to you need some gel, please. It's sad, but you have to memorize the gel, please. So, because it's the easiest way to deal with this thing. Otherwise, you would just get nuts. So, the first thing to do about this base-specific, to do about this process, you want to take one base out. How can I take one base out? Well, the first thing to do, you need to use a glycosylase, okay? To remove the altered base, and it creates an AB site. Okay, now let's see what we have. We have used a glycosylase and we have removed only one nucleotide, like the problematic one. Yes? Okay, done. What's next? One or more nucleotide will be removed by endonucleases, which cleave the 5' end, and an AB lyase, which remove the 3' end. You're like, well, you are giving me too much info. I'm not getting it. Well, let me tell you what's up exactly. So, if you take a look at this one, glycosylase is cut. Then comes the who? Gel, please, E, endonuclease. Yeah? So the endonuclease go to the 5' end. I hope you can see the 5' end. Come to 5' end, cut. 3' end, the lyase, gel. Yeah? So glycosylase. After that, we said the endonuclease, cut the 5' end. And the L for the lyase, that cuts the 3' end. So what are we doing? We are trying to basically mutilate the base and get the base alone and remove everything from around it. So we are done with the gel. We used the glycosylase, we used an endonuclease, and we used the lyase to keep the what alone? To keep the base alone. Yes? DNA polymerase will fill up the gap afterward and reseal the gap. So basically, to make it simple for you guys, we just remove one base, the one that we don't want, the one that is problematic, okay, by the help of a glycosylase, and then the polymerase comes in, put you the ones you have removed, but now it's not a pathological one anymore. Should uracil bind to guanine? Yes or no? Should uracil bind to guanine? Should not. Should not. So you need to convert the uracil into what? Cytosine. Yes. So you need to remove that segments and convert that to cytosine. But you are like, this is uracil. And that's where my job comes in. I'm collecting all of the typo in first aid. And here is one more. I'm loving this. Good. So basically, the gel please mnemonic will always get you the answer correct. Okay? Just know the steps. Glycosylase, remove the base. Endonuclease, cut the 5' end, which was on the sugar, of course. It was here. 5' end. 3' end cuts by lyase. And then the polymerase and the ligase comes in the ending, which reseal the gap. Okay, it occurs throughout the cell cycle. It's important for repair of spontaneous or toxic deamination. They never ask about this. They will literally tell you basic excision repair and expect you to know the gel please mnemonic. Okay? So the last one is the mass match repair. It's super important, not because of it's important, but because of the diseases it's related to. So mismatch nucleotide in a newly synthesized strand are remained and gap is filled and resealed. Well, let's take a look. When we say it's unmethylated, it means it's working or not working, first of all. Unmethylated. It's active, absolutely. Yes. Okay. So it occurs predominantly at the S phase in the cell cycle, and this thing will be destroyed, especially with which case? With something called Lynch syndrome. Lynch syndrome leads to colon cancer and also gynecological cancer. Write a note about this. So it can lead to gynecological cancer, also it can lead to gastric cancer, also it can lead to colorectal cancer. But this colorectal cancer will have no polyps, which is in contrast with the FAP, which is familial adenomatous polyposis. All of these diseases we'll speak about later, but when I speak about later, I will be telling you, oh, it's a defect of the mismatch repair. So what is the mismatch? Guanine should not bind to the adenine, but it's binding anyway, which means you have to remove this whole segment because he's mismatching. He's matching to the wrong one. So you remove the whole segment and put a new segment with a correct orientation, which connect the thymine. So the cancers that can be caused by this mismatch repair is the Lynch syndrome, which include the non-polyposis colorectal cancer, gynecological cancer, including ovarian and endometrial cancer, pancreatic cancer, and some forms of stomach cancer. Okay? So all of these can be happening because of mismatch repair. Okay, good. So if we speak now about, okay, you are like, man, this biochem is tough. Well, yeah, but to be fair with you, they just want you to know that ataxia-telangiectasia is related to the non-homologous enjoining. They want you to know that homologous recombination occurs in case of BRCA mutation, leading to breast cancer. They want you to know about the xeroderma pigmentosa and the nucleotide excision repair by creating a pyrimidine dimer. And they want you to know that the base excision repair is gel bleeds. They truly love this mnemonic. And finally, they want you to know that the mismatch repair is associated with Lynch syndrome. That's it. So a mutation in a DNA goes as follows. So the degree of change. So we have silent mutation, which means that you, before I speak about these, I should teach you guys what does a codon mean. So codons. I want you to notice something here. This is the sequence of the basically the RNA, yeah, because it has uracil, and this is what it will code for. So uracil, cytosine, adenine, and guanine. So if I have any change at the third position, if you see, the first two positions must be identical, but the third position, it's okay if it changes. It doesn't really matter. For example, notice CG, 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 but the last one is changing. CA, 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 the last one is changing. So only the third position change, and we call that the wobble position, okay? The wobble position. So if the wobble positions change, it's okay, no problemo, okay? It means that we will encode to the exact same amino acids because these sequences, each of them encode for an amino acid, yeah? You don't have to memorize this. You just need to understand it. So let's say that the first, we have a patient who had a mutation, and then instead of having, let's say, CUU, he had a mutation at the wobble position, and instead of a U, he got a C. He will be encoding for the same amino acid or for a different amino acid. The same amino acid. So will he have any symptoms? No symptoms. So since he has no symptoms, we call it a silent mutation. One more example. We had a patient that was encoding for valine, for example. Valine, yes, is the amino acid. GUU. And instead of GUU, he got a mutation of the U and it becomes GUG. Will this patient have any symptoms? Absolutely not. Why? The same amino acid he's encoding for, so he will have no symptoms. Okay, so they're right. Silent mutation is the best. If you had to choose a mutation, choose that one. So silent mutation codes for the same amino acid, often involve the third position of a nucleotide, which is called the wobble position, okay? So the next best is missense, which lead to change in the amino acid, and we call it conservative if the new amino acid has similar chemical structure. But if it had totally different structure, we call it to be not conservative. Conservative, it means like, oh yeah, it's a different amino acid, but it did not lead to that much harm. But if it was not conservative, it will lead to some harm. For example, in sickle cell disease, the substitution lead to conversion of a glutamic acid into the valine. Is that leading to a pathology? Absolutely. It leads to sickle cell disease. Thus, we cannot say that it's a conservative one. This is a non-conservative type of a missense mutation. So, okay. The next one is stop the nonsense. So, stop the nonsense. The nonsense mutation result in a stop codon. I don't know if this still exists in the first aid, but back in my time we used to say, absolutely. The missense mutation you mean, or the silent mutation, or from the beginning? Missense, okay. If we speak about the missense mutation, let's say we have a patient that originally had this sequence. So let's say he has I'm trying to find something that will fit on both of them. So CCU, and then I want another CC. Okay, let's say that we had a patient that originally had this amino acid, valine, GUU, okay? And that GUU now changed in the third nucleotide, yeah? Instead of a U, it was a A. That's silent mutation. There is no symptoms. But if we say that instead of the U, you got something weird. I mean, I don't know. Maybe you got against of the GUU, you changed the U into C. Okay? So it will become, instead of valine, it will become alanine. Yes? Instead of valine, it will become alanine. If we speak about the alanine, it's a totally different amino acid, which can lead to actual disease. Yes? But if this new amino acid will create a protein that has the exact same function as the valine, then it's okay. No problemo will happen to the patient. But if the new protein made has a totally different function, the patient will be sick. Okay? For example, in the case of sickle cell disease, as you can see here, we had conversion of a glutamic acid into valine. Okay? So the glutamic acid was converted into valine, like something like this. So the GAA was converted to GUA. Is the mutation at the Whipple position or a different position? It's a different position, not the Whipple position. Remember, please, the Whipple position was the third position. So this is at the second position, which can lead to actual disease. Yes? Okay. So you can see here that this patient will have the degrees of change. Silent is perfecto. Missense, we changed one protein, which can lead to some harm. Nonsense, we stop a whole codon. We just truncated. We just stop it in the middle of the process of basically translation, gene expression, sorry. And the frame shift is the worst of the worst. So let's take a look. The nonsense, it results in an early stop codon. So back in my time, we used to say, you go away, you are gone, you are away. Yes? These are the stop codons. Usually generate non-functional proteins. Thus, it's much worse than the missense, much worse than the silent. The other type, which is a frame shift mutation, which is a deletion of one of them, will make it bad. But before I speak about any of these, let me review the ones we already spoke about. So this is the original sequence. You can see GAG, and the mRNA codon was still GAG, which encoded for glutamine. Yes? While the silent mutation had a change, and at which position? absolutely, the wobble position, which led to which change? Zero change. Yeah, nothing has changed. So wait a second, this is a typo again. Oh, no, it's not a typo. All correcto, all correcto. So they changed the G, and instead of the G, they got an A, but it coded for the same thing, so that was okay. The third one was the missense mutation. The missense mutation is, instead of glutamic acid, we are coding for valine, which causes sickle cell disease, yeah? And the nonsense mutation, it's encoding for one of the stop codons. You are gone. So that stops the whole process. Okay, let's speak about the frame shift. So the frame shift mutation, it's adding or removing one of the nucleotide. That's a horrible idea. So deletion or insertion of any number of a nucleotide not divisible by 3. It will lead to misreading of the nucleotide downstream. So all of the downstream nucleotide will be shifted, which will lead to the, like if you add one more, all of the downstream will be shifted. Because when we encode for an amino acid, how many nucleotides do we need? How many nucleotides do we need when we code for an amino acid? Yes, we need 3 of them. 3 of them, absolutely. So to code for one amino acid, you need 3 nucleotides. So if I'm going to shift them to the right, all of the sequence that will come after will be messed up, okay? So they write, misreading of all of the nucleotide downstream, protein may be shorter or longer, and its function may be disrupted or altered. For example, the Duchenne muscular dystrophy and the Tay-Sachs disease. Notice, these are super serious diseases because they are due to a frame shift mutation, the most serious type of a mutation between all of them, okay? So, just want to show you a quick frame shift mutation animation, just to get an idea about what's happening. I hope I will find. Yes, notice here what is happening. So here we have the sequence. This is the transcription process. We have the amino acid sequence, yeah? And let's say you added 1. So this is an insertion type of a frame shift. So this sequence will get messed up, this sequence will get messed up, this sequence will get messed up. So initially we used to code for proline, we used to encode for leucine, serine, cysteine, proline, leucine, and lysine. When you entered one here, see all of the downstream one, they have shifted to the right. So that leads to which problem? Take a look. The mutated mRNA now, because you added 1 of them, so this is the first strand, the next strand will encode for it, the mutated mRNA, this is the DNA, this is the RNA. Now the leucine, serine, and the cysteine will stay okay, but the problems will occur after the insertion. So now, threonine, totally different amino acids. All of the amino acid sequence downstream is totally defected. The same idea when you remove an amino acid, okay? So that's a frame shift mutation. Okay, so splice site mutation, retained intron in the mRNA. Basically, I will be telling you in the future that our inside of the mRNA, we have something called introns and something called exons. Exons get expressed to mRNA. Introns should not. And that is done by some mechanism I will tell you about later, which is by the spliceosome and all of that, but this is for later. But when we have an intron in the code, so let's say that this is mRNA, it has exons, introns, exons, and we should in the end only get exons. We should have no introns, yeah? If you accidentally get an intron in between, that's a big time trouble. If you don't splice it out and it stays in between, you are going to have really serious pathology. So there is a chance of cancer, dementia, epilepsy, types of beta thalassemia, Gaucher disease, or Marfan syndrome. You don't have to memorize these. The main idea that it will be shitty. It will cause super serious problem in these patients. Okay, good. So that was one of the most difficult topics in the book. So congratulations on finishing that. So the next thing is also not an easy topic. It's the laccaberon. This biochemistry stuff, guys, is difficult. I cannot lie and tell you, yeah, it's super easy. No, it's not. But it's something that you must go through. So that's what we are doing today. So I will take a little break now, guys, and I will see you back in 10 minutes to continue our discussion about the laccaberon and then move forward to see what we are going to do. See you in 10 minutes. Hello everyone, welcome back. So let's continue with our topic regarding the laccaberon. So anytime somebody hears about the laccaberon, they get constipation. Why? Because it's difficult. Not really. So the laccaberon is not that difficult if you understand what is the idea. So the idea of the laccaberon goes something like this. Normally the E. coli, forget about everything written here. So the E. coli, this is an E. coli, okay? E. coli is a gram-negative bacteria. So the E. coli normally eats what? What does the E. coli like to eat? What does it use for eating? Food. What do you think? Glucose, absolutely correct. It uses glucose. So, well, if glucose was not there, it must use something else. It uses lactose, okay? It uses lactose if glucose is not available, okay? So, the idea here that you need to understand how can the bacteria, the E. coli, uses the lactose when glucose is absent, okay? So, let's start with speaking about this laccaberon. The laccaberon, to start with, ATP will be converted to cyclic AMP, and that will be converted into the cap. The cap will be binding to its site, and after it binds to its site, it will activate the promoter, which will lead to downstream movement, leading to encoding of some genes, which will make some enzymes, and these enzymes will metabolize lactose and get you glucose out of it. Yeah, so you are like, wow, that's a long type of thing. You spoke about a lot of things. Yes, I spoke about a lot of things, but I will speak about them 5 more times in different ways. So to start with, if you have a glucose, should you use lactose for the bacteria? No, not needed. So you can see the glucose is inhibiting the adenylate cyclase. Yeah, so will I have cyclic AMP? No, I will not. Okay, if I don't have cyclic AMP, can I have activation of the laccaberon? Nope, absolutely not. Okay, good. So, okay, the first step that the glucose inhibit the laccaberon, because the laccaberon is for the usage of lactose when glucose is not available. They write, it's a classical example for genetic response to environmental change. Glucose is the preferred metabolic substrate for E. coli. But when glucose is absent and lactose is available, the laccaberon activated to switch to lactose metabolism, and the mechanism of shifting is what we are going to speak about right now. So when you have low glucose, you will have more conversion of ATP to cyclic AMP. Why? Because the absence of a glucose will lead to adenylate cyclase to go up or down. No glucose, what happens to the adenylate cyclase? Absolutely, it goes up. So then the adenylate cyclase goes up, you will have more cyclic AMP. Yes, look what they write here. More adenylate cyclase activity, more generation of cyclic AMP from ATP, which lead to the activation of the cap. Yeah, what is the cap? It's the catabolite activator protein. So that catalyte activator protein will go to and bind to its receptor to this thing. Well, what is the laccaberon? Well, the laccaberon is a sequence on the DNA of what? Of the bacteria. Yes, it's a sequence of on the DNA of the bacteria. So when the cap binds to the cap sites, it will go and activates the what? The DNA polymerase. Notice, guys, see this red one? This red one, we call it DNA polymerase. Yeah? And when it activates that, notice what will happen. Boom, 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 boom. Movement. Yes? Okay, so you move forward and you encode for that guy. Okay, so if you do not have a glucose, you must use lactose. But to use lactose, you must have lactose. If you don't have lactose, can you use the laccaberon? No, no way. It's not possible. Basically, the idea is like this. The idea of laccaberon, if the glucose is absent, we use the lactose. But if the glucose and the lactose are not available, if both of them are down, okay? So glucose is low, lactose is not available. Will the laccaberon work logically? The answer is absolutely not. It's not possible. So let's see why. Well, take a look here. They write here allolactose, but for the sake of my explanation, look at it as lactose only. So when the lactose is available, it will bind to something called the repressor protein. Notice here, the repressor protein is normally binding to the operator site, preventing the DNA polymerase from moving forward. So if we want the DNA polymerase to work, what should we do with the repressor site? What should we do with the repressor? I'm sorry, what do we do with the repressor? What should we do with him? Inhibit it or remove it. Yes. How can we do that? Well, the repressor normally bind here. But if you have the lactose, it binds to the repressor. Yeah? When it binds to the repressor, what will the DNA polymerase do? It can keep going. Yes? When the DNA polymerase keeps going, it will go to something called the LacZYNA, which makes some enzymes you do not have to know. When these enzymes that you do not have to know work, you will have making of what? An enzyme that can metabolize, do metabolism of lactose. Okay? So let me make sure we have some understanding here. So I will read the last sentence and then I will ask a few questions, and I hope you guys will be interactive with me. So in case of high lactose, it will unbind the repressor, which is this guy, from the operator site or the repressor site, which is here, which increases the transcription because there is nothing to move in its way. So let me ask the following now. If I have a plenty of a glucose and a plenty of lactose, will I be using glucose or lactose for the bacteria? Glucose, obviously. If a glucose is absent and lactose is available, what is going to happen to the adenylate cyclase in the laccaberon? Absolutely correct. It will go up. So the ATP will be converted into cyclic AMP, which binds to the cap, which is what we said, the catabolite activator protein, which binds to a specific portion on the DNA sequence of the bacteria. And that activates this red particle. What is the red particle? What is the red particle here, guys? DNA polymerase, which lead to the movement, but it faces some blockage here. What is this? What is this? Something preventing it from moving forward. The repressor protein, absolutely. So how can I remove the repressor protein? I should have what inside of the bacterial cell? What should I have inside of the bacterial cell to remove the repressor. I should have lactose. Yes. So basically, absolutely correct. You need to block it with lactose. So some lactose will come, will bind to it. And when they will bind to it, you will inhibit the whole repressor from binding to the operator side. If nothing is in the operator side, can DNA polymerase move forward? Yes or no? Can DNA polymerase move forward if no repressor? The answer is yes. If it moves forward, it will lead to activation and basically gene expression of the LAC Z, Y, and A. What do they make, these genes? Enzymes, absolutely enzymes. And these enzymes are responsible for the metabolism of lactose into glucose and for using it for energy for the bacterial cell. Nice. So now we can speak about these guys. Notice, from the LAC L, here we have LAC L, we have the cap site, we have the promoter, we have the operator, we have the LAC Z, Y, and A. Let's start with them one by one. The LAC L is responsible for making the repressor, okay? The LAC L make the repressor. The repressor activated or inhibited the LAC aberon. Well, its name is repressor, so it must inhibit, okay? So the LAC L actually inhibited the LAC aberon. Okay, the cap. Guys, if we say the patient have a low activity of the oh no, forget about this question. Let me put this question. If the patient has plenty of a glucose, will the cap bind to the cap site? No way. It cannot bind to the cap site. A lot of glucose, it will inhibit this guy. There will be no activation of cap. It will not bind here. Okay. So let's say the glucose is low, cap binds to the cap site. At the promoter site, we have the DNA polymerase located, which was activated by the cap. And at the operator site, we have the repressor binding here, what removed the repressor from its place? What was able to remove the repressor from its place? The lactose, absolutely. So now we have the 3 genes encoding for 3 enzymes. You don't have to know their names. And as you can see, all of them start with AUG, AUG, AUG. What is AUG? You are close, but it's not the stop, it's the start codon, which is the starting of encoding for the enzymes, the 3 enzymes, yeah? Which metabolize the lactose. Okay, let's speak about the following stories. If you have low glucose and high lactulose, step by step, what is going to happen to your cyclic AMP? In this state, cyclic AMP, up, okay, CAB activity, up, repressor activity, down because what binds to the repressor? The lactose. Nice. Okay, and what is going to happen to the transcription of the enzymes? Up. Okay, done. So that's the first state. It's the perfect state. The cap is activated by the low glucose, basically, increased cyclic AMP. And the DNA polymerase is active and it's able to move forward because there is no repressor to inhibit it because the lactose took him away. The LAC genes strongly expressed and they are able to metabolize the lactose. In the next state, we have high glucose and lactose unavailable. Should the LAC aberon work in this state? Yes or no? There is no point from it working because the main idea of the LAC aberon was to get more it used to work only as a survival mechanism. When you don't have glucose, you have lactose. So the lactose unavailable, so the repressor will be sitting And the high glucose, if you have high glucose, what happened to cyclic A and B? It will go down. If it goes down, what is going to happen to the cab? Will the cab be activated? Nope, it will not. Absolutely correct. So you cannot see it here. So they say lac gene will not be expressed. The next case is a low glucose and the lactose is unavailable. So the lactose is unavailable and the glucose is low. Let's see what happens here. So low glucose, lactose are unavailable. Low glucose, okay. If there is low glucose, what happens to cyclic A and B? Up, cap, no, low glucose, remember, low glucose, adenylate cyclase will be activated. That lead to the CAM be activated. The cyclic A and B will go up, yes? So again, when we have low glucose, what happens to the cyclic A and B? Okay, so low glucose, up cyclic A and B. What is going to happen to the CAB? Will it be activated or deactivated? Absolutely activated, it will go up as well. Okay, when the galactose is unavailable, will the repressor be active or inactive? It will be active. Remember guys, the repressor used to repress when there was nothing to stop him. But when you had the lactose, it used to stop him. Yes? Okay, the last condition. Oh, so they say lactobaron will not be expressed because you have, yes, you have low glucose, but you will not have any lactose. So no lactose, the repressor will be here. It will prevent the DNA polymerase from encoding for the gene. Yeah? It will prevent him from expressing the gene. The last case is high glucose and lactose is available. Well, if I was a bacteria, which one I would take? Well, a fresh, nice glucose or a lactose that needs a lot of work? Of course, the glucose. Just the glucose. So that's everything on the lactobaron. I hope it was not that difficult. So the next topic we are going to speak about, let me take a quick look. Okay, so from the biochem, the molecular chapter, we have 1, 2, 3, 4, 5 pages left. So I would not like to give you all of the pages in the same day because this material is just like heavy, you know. So every day I would like to give you like 2 pages, 1 pages until we finish it, the molecular biology. The one after it, which is like the cellular biology, is a little bit easier because it has some actual pathologies into it. Genetics, some students find it difficult. And then we have the metabolism. Some people find it hell, some people find it easy. But the lipid metabolism, everybody agrees on, it's bad. So let's speak a little bit about micro. To continue with the antibiotic, we are going to speak about the what will be next, which system. That's not my choice. Wait a second, I will tell you. Just a moment. Oh my god, come on guys, somebody just vote on this one to break the vote thing. Okay, please somebody vote here so we can decide. It's a tie between gastro and pharmacology general. It's up to you. Pharmacology general is heavy, gastro is super easy. So next thing, let's see. We have a protein synthesis inhibitor. The protein synthesis inhibitor antibiotics. Well, if we speak about the human ribosomes, they include 2 subunits. The first one will be the 30S subunit and the 50S subunit. But wait a second, this is a human or bacteria? Of course bacteria. We will not give antibiotic for a human. We can inhibit these ribosomes in a human, but why would we do that? Why would we inhibit ribosomes in a human? In some chemotherapeutic agent. So protein synthesis inhibitors. So remember guys, really just I want to check your knowledge for a second. Can somebody tell me what do we call the process of converting DNA to DNA? Replication. How do we call the process of converting DNA to RNA? Okay, transcription. How do we call the process of converting the RNA into protein? Translation. And how do we call the process of converting a DNA to protein? I mean both transcription and the translation. Yes, we call it gene expression. Absolutely correct. Okay, so we can comfortably now speak about this. So during the process of translation, which is converting the mRNA into a protein, there is a few steps that occur. For example, we have the 30S subunit and the 50S subunit of the bacteria. It's normally encoding for basically what? It's encoding for a protein. And our function as doctors is to activate or to deactivate the protein synthesis of the bacteria. Deactivate, we want to paralyze it, we want to kill it, so we want to deactivate this process. There are so many steps we can attack to do that. So it starts with the A30. I hope you remember the mnemonic I told you the other day. I told you it's a A30. So it's aminoglycoside and 30, which is tetracycline, work at the 30S subunit, okay? Or someone says like buy at 30, sell at 50. It's up to you how you memorize it. So personally, I like sketchy. That worked for me perfectly. I mean, for the antibiotic and antimicrobials, it's up to you what you decide. So linezolid binds to the 50S subunit. Aminoglycoside is one from the AD30, so that works at the 30S subunit. And they both work at something called the initiation process, okay? So for the sake of doing the translation process, so the translation, there is 3 steps we have to take. The first one is the initiation. The next one is the elongation. And the last one is the termination, okay? So initiation, elongation, and termination, okay? So there is little minor steps between them, but these are the main steps: initiation, elongation, and termination. So at the initiation step, we have so far aminoglycoside and linezolid inhibiting this process. So the initiator tRNA, which hold what is the function of tRNA? Basically, to transport around amino acids. Notice here, there is like a little particle here, yeah? And this is basically a protein, okay? And this, like methionine or histidine or whatever, it's an amino acid, yeah? And it takes this amino acid and it bear it at the ribosome at the P subunit with an exact codon, okay? And this is how the translation occurs, one amino acid at a time. So you can notice the first one took this amino acid. Then one more tRNA comes at the next one. And this machinery just keep moving and adding more amino acids, yeah? So notice now. Now it's going down here. So this methionine now will jump into the histidine. And now we are starting to make the polypeptide. Now it will keep moving. So when it moves like this, of course it moves like this. So when it moves to the E position, it will be, I like to think about E, it's excreting it. So the tRNA, the used one, does it have an amino acid on it anymore? Can you see any amino acid on it anymore? The answer is no, no amino acid. So it will be thrown away, not needed anymore. So a new nucleotide will come and bind to the A position, and the cycle keeps repeating, and they keep throwing back the amino acids until they make a long chain of polypeptide. So the process of starting this mechanism, we call it initiation. The process of constantly adding a new amino acid, we call it elongation. And the last step will be termination, in which like we had already made our amino acid. And what will tell us that we have finished one of the stop codons? you are away, you are gone, or you go away. Okay? When the sequence is seen as that, it will be cut off and the polypeptide will be released. Yes? So we need to attack different areas in this process to stop this thing from occurring, which is the protein synthesis in the bacteria. They write, tetracycline binds at the A site, which was the loading site of the tRNA binding, okay? And the chloramphenicol bind to the peptidyl transferase, okay? And the macrolide and the clindamycin bind at the translocation, like prevent the translocation. There was this mnemonics, I don't know if it will work for you, but it says a clean Mercedes transporters, or a transport clean Mercedes. Oh, a transport cleaned Mercedes, transport clean Mercedes, which is translocation, macrolide, and the clindamycin. A transport clean Mercedes, if that works for you. Okay, chloramphenicol, it's a drug that is famous, leading to one disease that we will study about. It will be interesting if somebody know it. What does chloramphenicol can lead to? Which disease can happen because usage of chloramphenicol? Oh, nice. Okay, it's a gray baby syndrome. Gray baby syndrome. We'll study it later. Don't worry about it. But like we did not do it yet. But it's interesting that somebody actually know about that. But it can lead to gray baby syndrome. So anyway, it's like peptidyl, if it works for you. Peptidyl transferase, okay, chloramphenicol. And the tetracycline at the tRNA binding site. Okay. So as you see, this is a general graph that we will have to go back to. It's specifically target the smaller bacterial ribosomal subunit 70S, which is made out of 30S and 50S. Guys, do the math. 30S plus 50S. How the hell is 70S? It does not fit. Well, yeah, because we are not speaking about weight. The S is the speed at which the centrifuge is going, you know? So they are telling you, we are able to detect the 50S subunit when the centrifuge is moving 50 rounds per second. While we detect the 30S subunit when the centrifuge is moving 30 at speed 30. And the 70S is when we can detect the whole ribosomes when it's binding at 70. So it's not a unit of measurement, it's not a unit of volume, it's actually a unit of speed. So since it binds at the 3 and 50S, it will not affect the human cells, which is perfect. That's exactly what we want. All of these are bacteriostatic, except aminoglycosides, which is bactericidal, and linezolid, which is variable, which means bacteriostatic, that will have less risk of developing which problem? If we have a bacteriostatic drug, it has less risk of developing what? Yep, absolutely. It will have less risk of developing septic shocks. Okay, good. So if we speak about these drugs, just pure memorization. And now we are going to speak a bit about aminoglycosides. So the aminoglycoside family goes something like this. We have all of the ones end with mycin. So we have gentamicin, neomycin, amikacin, tobramycin, streptomycin. Hopefully you did the sketchy for this one. All mycin. So bactericidal. It was the only protein synthesis inhibitor of a bacteria that is a bactericidal. The other ones were bacteriostatic. Irreversible inhibition of the initiation. We saw that. It was the initiation complex through binding to the 30S subunit. It can lead to misreading of the mRNA and also can sometimes block the translocation, but it's not mentioned here. It requires O2 for the attack. That's a problematic because it needs O2 for the uptake. That means the bacteria we are killing must be aerobic, which is not always the case, you know? So that's a problematic. Therefore, it's ineffective against the anaerobe. So aminoglycoside only works against the aerobic. So can you use it against Fusobacterium? Yes or no? Can you use it against Fusobacterium? No, you cannot, because Fusobacterium is anaerobe. The clinical use, it's used for the severe gram-negative road infection, and it's synergistic for the beta-lactam antibiotic. How is it synergistic in the beta-lactam antibiotic? I told you about this today. Yes, absolutely correct. It destroys the wall, no wall leading to the aminoglycoside being able to enter the cell immediately and directly without the need of being uptaked. Yes? So if this is the cell wall, this is the nucleus, these are the ribosomes. The beta-lactam antibiotic will destroy the cell wall. Yeah? The aminoglycoside will go directly to the ribosome and inhibit them directly. So clinical use, we can use the neomycin for bowel surgery. Does anybody remember where we spoke about neomycin? Does anybody remember in which disease, in which parasitic disease, we spoke about neomycin? No? Neomycin. Okay, so we used to use it for the antamoeba histolytica. Yes, okay, so we used to use it for antamoeba histolytica, and it used to work only inside of the intestine. Yeah, and we had one more type of them that was called baromycin. Yeah, as well. So the adverse effect of the aminoglycoside, as always, any drug that is nephrotoxic, think about ototoxicity as well. Okay. So nephrotoxic, ototoxic as well. It has some problem, and this will be super high yield when we do neurology. It leads to neuromuscular blockade, which makes it an absolute contraindication for someone with myasthenia gravis. Remember, myasthenia gravis is these people who are in the morning are really energetic, and by the time it's at night, their acetylcholine receptor is totally depleted and they become super tired. They can have ototoxicity, especially with the loop diuretic, because this also is ototoxic, and teratogenicity, so do not give it for the babies, okay? Mechanism of resistance, the bacterial transferase enzymes becomes inactivate the drug by acetylation. So the transferase in the bacterial cells is like, okay, yeah, we are bringing in aminoglycosides, and that's not a good idea. So let's deactivate it. How? Acetylation, phosphorylation, adenylation. Basically, biochemical reaction that inhibits the transferase enzyme that intake the aminoglycoside inside of the cell. Okay, guys. So for now, I will call it off. But for tomorrow, please, please, please do the antibiotic videos from Sketchy. That will help you a lot. So tomorrow we'll do one. Today we finished 5 pages, which is good. That was the plan. So we'll finish 1, 2, 3, and we finished 2 from Biochem, which is kind of difficult actually. So tomorrow we'll finish 1, 2, 3, 4, and 5, hopefully 6. We'll see. Okay, guys. So see you tomorrow, and goodbye, everybody.